Ah, no pasa nada. Hello. Hello, everybody. Good afternoon. Um, Today we have a very interesting case. I want to say thank you before than all to all the participants of our endoscopy congress and gastroenterology congress uh, that was made few weeks ago. So now I want to say thank you. We had 1,200 physicians registered. Thank you for the industry supporting us. All the companies that were we us that were with us, and also to all the faculties that came here to make lectures and teaching us to all the country. The new techniques and new approach for patients. So today we have a very nice case. This patient have an alterated um, anatomy because of gastric cancer and surgical resection. So this patient had failure, ERCP failure, because they didn't reach the papilla, and now we are doing an antegrade treatment. So I'm inside the biliary tract. You can see guided by US, very well done by my assistant, Dr. Daniela Tabachella, that helped me to find the biliary tract. So that is very good. And now I have my guide wire there. You can see I'm not in a good position, in a fantastic position, but I am inside the biliary tract. So what I always do is I let the guide wire inside to avoid to make more punctions with the needle. And now you can see here in the US, you see, I'm going to go in. I'm going try to go inside the biliary tract now. I think just one little more. Okay, so now I think I am inside. Puedes inyectar contraste. So now I will put contrast just to see if I am inside, and then I will move the guide wire. That is what I will do. No, quiero que metas contraste. No veo nada. Ah, no, no estamos ahí. Okay. So I have to. Inyecta. So now we are. Okay. I will push a little bit. Ten la guía. Okay. So now. No. Necesito mover la guía. Ten ahí. Necesito irme hacia adentro un poco más. Solo témplame la guía. Okay. Now. Necesito retirar la guía un poco. Ok, no hagas nada. Ok. Déjala ahí, vamos a cambiar, quiero un esfínterotomo. So I will change now by one esfínterotomo. I will less the guide wire. You see the guide wire is not fantastic. It's broken. But I will recover that and we will change it. What I will do is try to put in the correct way. So now I will use one sphincterotomy. I can change the tip so I can make a direction, better direction of the guide wire and put it in the good way that I need. What I will do today is just try to reach the biliary tract by antegrade way. Then I will try to do a balloon dilation and try to move some stones that are in the biliary tract in the other direction. And then I will also less one fistula from the liver to the the biliary tract to the stomach, hepaticogastrostomy fistula, because I need that, and after that we can move forward. You see, now I'm inside. Mete contraste. Okay. You see, I'm in the biliary tract, so I'm perfect. Ahora necesito que muevas primero veamos si podemos. Y ahora sí, empuja la guía, sácame otra, dame otra guía. Esta guía no vale. Yes. Si me das una de 0.25 te lo agradecería, ¿no? So now I will change the guide wire. I am inside, I believe. I will use one 0.025 guide wire now, because I don't have too much space. So let's see what's going on. Dale. Empuja. Dame acá. Ok, empuja. Empuja, 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 empuja. Sigue, 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 sigue. Dame acá. Empuja. Ok, ten ahí para yo empujar. Empuja. Sigue, 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 sigue. ¿Puedes o no puedes? Momento, ten ahí. Ten. Ok, ahora retiras. Ahora empujas. Inyecta contraste. Ok, estamos como que un poquito fuera. Ok. empuja. No, esa es la fístula que tiene ahí. Ok. Ok, empuja ahí. Un momento, dame un segundo. Empuja ahí. No, retira. Dame una 0.35. I will change the guide wire now. Sometimes it's not so easy. He doesn't have a big dilation. The other step that we can do it when we are in this situation is to get out and go inside again. But I believe we are inside, huh? Pon contraste. Pon contraste. No estoy tan seguro. Okay, dale. I will try again, but I'm not so sure. No, retira. Okay. So I will make a second position. Now I have a guide. Better guide. So I will search my biliary tract from this position a little bit far. A ver, presta. Sometimes it's not the best, but so I am using a 19 gauge needle. Okay, let's see. It's very important to be inside the biliary tract, and I will try to confirm that. Okay, let's see. Okay, I will see. Maybe we are not. Contraste. I think we are not. I think we are not because. So you see, when it disappears quickly, it's because you are in the vessel. So I'm not in a good target. I need to find out my target. See. Better target. But I am trying to reach the common bile duct. I think we can reach here. Let's see what we have here. Little difficult, huh? Okay, so this is the bile duct, this is the portal ray. Sometimes it's difficult because we cannot see very well where is you see here this anastomosis endoscopically. It's a little difficult, huh? So now okay, I'm very far. Puedes purgarla. So each time when you attempt, you need to clean your needle, because if not, the coag goes inside and you cannot reach the biliary tract. So let's see now. I am trying to find out other window to see if there is any place where I can go. No, this is very distal. Let me see deeper. I'm trying to see my needle. Okay, I'm not so bad, huh? So this is very important, that you need to see where is the needle. Sometimes it's difficult, but it's not impossible. So I see my needle here. It's very okay. I will make a zoom to be sure to see where is my needle. Okay, so now I will move a little bit. I believe there is tissue inside, that's why I cannot make an aspiration. Creo que hay tejido adentro, pero what I will see is where is the tip of my needle. It's a little bit difficult to see where is it. Okay, now I'm inside. I'm inside. Okay. Okay, contraste. Now I am inside. Yes. So, you see, it's a little bit difficult, huh? Dame una 0.25. I will use one 0.25 guide wire. So it's very important, once you reach the biliary tract, the first is try to avoid, to get out. But sometimes if you need to get out, once you have contrast inside the biliary tract, it will help you in both ways. One, looking for the biliary tract, not just by EOS but also by fluoroscopy. And second, you see, now I am inside. Perfect. I am perfect now. You see, my guide wire is going down. Perfecto. Empuja. So now I am in a better position. So what I will do now is, you see, here is, ponme la imagen ecográfica grande. Here you can see the needle. You can see here the needle inside the biliary tract. So now, little difficult, huh? Really difficult. But it's not impossible, huh? Once you are inside, it's perfect. Don't worry about see. Okay, now we will move with remove the zoom, and now we go inside. So there is some questions. First, what happened with the first hole that we do it? It will not happen nothing, because you have the liver there, so it's 6 French cystosome, so it will close. I don't need to close that hole because it's really small. First. Second, what happened with the new one? It will work perfect. So the liver is very, how to say, very friendly organ. So we can reach in a good way directly this situation, and I believe we are perfect now. So I will pass now the cystosome again, the 6 French cystosome, and then I will reach to try to pass the papilla. But I will change my guide wire. I will use a 0.35 once I reach the biliary tract in a correct position. So the way that we work with this is the same way that work the radiologists. You know, the radiologists, what they do is with a needle they make a punction in the, you know, little bit blind because they use just X-ray and or CT scan, for example, and then when they reach, okay, ahora voy a cortar. So this is important. You need to see if there is any vessel, the tract. I don't see any. You see here is my tract, and the vessel is here. So I'm very safe. I'm safe. So now I will cut. Pero no veo. Ah, ok. ¿Puedes clarificarlo mejor? Está muy oscuro, muy opaco. Ahí se ve mejor. You see? Now, it's better. So now I see my catheter. You know, the cystosome is there inside the biliary tract. What I will do is to push the catheter more. You see, now I am just down. Now I will remove my guide wire, you see now, and put it in a better position. Quiero ver abajo. Ok, ten ahí. Empuja. Empuja. Ok. Ten ahí. Empuja. Ok, ten, retira. Okay, now we pass. You see? Very well. So what I will do now is to follow with my catheter, and I will change with a 0.35 guide wire. Okay, now I am inside the small bowel. You see? Okay, we will make contrast just to confirm. Sí, inyecto. You see, there's the small bowel. It's okay. Perfect. You see? Perfect. Photo. Okay, now I will change the guide wire. Una 0.35. So as you can see, we need to use a lot of materials in this kind of cases. However, it's I believe it's safety, and it's much better than do it, you know, by enteroscopy, or, you know, it is difficult. You know, enteroscopy takes at least 2 hours. You know, in experienced hands, I believe, a little bit less. And you need, yes, that's true. Daniela said that true. Special accessories. Okay, now I will remove my catheter, and I will pass a biliary tract balloon dilation first. Primero bueno, pasemos el balón, intentemos pasar el balón directamente. 10, 11 y 12. So I will pass a balloon of 10, 11 and 12 to make a dilation of the papilla, and then I will pass a balloon, you know, extraction balloon. Maybe we will need to make some lithotripsy, but that will not be performed now, because what I need now is to treat the high levels of bilirubin and cholangitis, and then I will retake the patient if I need it. First, the first step is to make the drainage.
¿Salió? ¿Salió?
So let's see if that's pass. I believe it will pass. But if not, we need to use. If doesn't pass, we will use balloon dilation for biliary tract first. We are inside. Yes. Empuja. 10. 10. We are inside. That's why you need 0.35 guide wire. My balloon is going down. My balloon is there. Perfect. Now I will start to make a dilation. This is anti-grade drainage for stones and and obstruction in cases of anatomic alteration of the biliary tract. So now I am making the dilation. You can see through the papilla. Sigue, sigue, sigue. Hasta 12 sigue, sí. Perfect. Picture. Very nice picture. Okay. Now. Okay, desinfla. Okay. Necesito otro balón para dilatar. 12, 13 y 14. Préstame el esfinterótomo primero. Yes, I want to see very well. Because even with the balloon dilation, I don't see that the papilla, I saw the papilla, like the dilation of the papilla, but I don't see the contrast going out quickly, and this is the effect that I need. So I will see now.
¿Salió?
Ten. Ok, inyecta contraste ahí. You see, very thin papilla. Then. Yes. Yes, it's perfect. Okay, empuja. I will make a second dilation with 12, 13. Because I'm not so happy with my dilation. So one of the risks of this technique is to have pancreatitis because of the balloon dilation.
Salió.
Ok, dilata ahí. Okay. Now we made a big dilation. Okay, desinfla. Okay. So what I will do now is just to put a plastic stent, less the fistula, and coming back to make a lithotripsy. I will not do it today. It's too much. Perfect. Now it's better. Okay. I will not less my plastic stent until the papilla. What I will do is just to less inside the biliary tract, making a drainage to the stomach, and with the balloon plastia that we already made it, the contrast will go on. So it is okay. C'était French. Yes. Okay. So now I will lay a plastic stent just to maintain the fistula, and after 3 weeks I will retake the patient to do a lithotripsy. So I will show you how to do it. So my stent is there. I think it's okay now. So I don't need to pass the papilla. I prefer that the papilla stay functional, and I will deliver my stent inside the lumen. No veo. Quiero ver arriba. So once you are inside the biliary tract, it doesn't matter. Now I'm fine. I'm very fine. Oh. Quiero ver arriba. Más arriba, la punta del endoscopio, hijo. No veo bien. Okay, but I'm in the lumen. I'm inside the lumen. Okay. So I will deliver it. I saw my catheter now. Libera.
Libera.
Sí, libera. Okay. So now it is perfect. Here is the sorry. I will flush. I will flush and I will see where is my stent, and that's all. Dame un gastroscopio. Oh, here. Here's the stent. You can see very well. Okay. So I will less there. Some bleeding is normal, but you see, it's not bleeding more, so that is good. And we need to retake this patient. That is what we will do. You can see very well it's in the stomach and in the biliary tract. So with that, the jaundice will become better, and I will retake in 3 weeks to make a lithotripsy, US guided lithotripsy, and and remove the stone. Thank you so much for your kind attention, and I hope to see you soon in our online congress in August. So